Vitamin B6 is one of the most pharmacologically vulnerable nutrients in the body, interacting with a vast array of common medications. Over 50 drugs are known to interfere with its absorption, metabolism, or function, yet this reality is almost entirely ignored in mainstream medical practice. The result is that countless patients taking everyday prescriptions may be sliding into B6 deficiency without ever being warned, tested, or treated. This isn't a fringe concern. It's a systemic blind spot with real consequences for neurological, hormonal, and metabolic health. The list of drug interactions with B6 is extensive and spans across therapeutic categories, from antibiotics to antihypertensives, from anticonvulsants to hormonal contraceptives. Some drugs accelerate the breakdown of B6 in the liver. Others prevent its conversion into the active form, pyridoxal 5-phosphate, or PLP, and some directly inhibit B6-dependent enzymes. Many of these medications are prescribed long-term, even for life. But B6 depletion is almost never part of the risk-benefit conversation when treatment plans are made. In most cases, it's not even mentioned in the patient information leaflet. Let's start with one of the most common culprits: oral contraceptives. Millions of women take birth control pills daily, often starting in adolescence and continuing for years, even decades. These synthetic estrogens and progestins increase the metabolism of B6 and interfere with its conversion to PLP. Clinical research going back as far as the 1970s has shown that women on the pill have significantly lower B6 status and may experience symptoms like depression, irritability, low energy, and even neuropathy as a result. These symptoms are frequently misattributed to stress, hormonal changes, or psychological causes, while the simple intervention of B6 supplementation could offer relief. Still, routine monitoring or supplementation is almost never offered. Another major class of B6 depleting drugs includes antituberculosis and antibiotic medications like isoniazid, cycloserine, and penicillamine. Isoniazid, in particular, forms a hydrazone complex with B6, inactivating it and increasing urinary excretion. This effect is well known in infectious disease circles, which is why patients on long-term isoniazid are sometimes co-prescribed B6, usually 25 to 50 milligrams per day, to prevent neuropathy. However, even this practice is inconsistently applied, and other drugs with similar effects rarely come with such precautions. Patients on cycloserine or penicillamine, for instance, often don't receive the same support, even though the mechanism of B6 depletion is comparable. Then there are antihypertensive medications like hydralazine, still prescribed for blood pressure and heart failure, known to interfere with B6-dependent neurotransmitter synthesis and homocysteine metabolism. Long-term use has been linked to symptoms ranging from anxiety and depression to paresthesia and impaired cognition. Yet patients are typically not warned about potential B6 depletion, and doctors rarely screen for it. Instead, worsening symptoms may be blamed on aging, cardiovascular disease progression, or unrelated mental health issues. Anticonvulsants such as phenytoin and phenobarbital are also notorious for reducing B6 levels by inducing hepatic enzymes that accelerate its metabolism. Ironically, B6 is crucial for proper GABA synthesis and overall neurological stability, exactly what these drugs aim to support. Inadequate B6 can not only diminish the effectiveness of the medication but increase the likelihood of side effects like fatigue, mood swings, and cognitive fog. Alcohol deserves special mention, not just as a drug that interferes with B6 metabolism, but as one of the most socially accepted neurotoxins. Chronic alcohol consumption depletes B6 through a combination of liver stress, poor absorption, increased excretion, and competition in enzymatic pathways. This is one reason why alcoholics are so prone to peripheral neuropathy, Wernicke's encephalopathy, and mood disorders. Yet, even among heavy drinkers in clinical settings, B6 status is rarely evaluated unless there's an overt neurological crisis. In moderate drinkers, the impact is even more insidious: slow-burning depletion that's never addressed. This pharmacological assault on B6 would be less concerning if the body stored large amounts of it, but it doesn't. Like other B vitamins, B6 is water-soluble and must be replenished regularly. The daily recommended intake, 1.3 to 2 milligrams, is barely enough for maintenance in a healthy individual, let alone someone taking one or more B6 depleting medications. And because deficiency symptoms can mimic other conditions, fatigue, anxiety, depression, numbness, hormonal imbalances, they're rarely traced back to B6 unless a clinician is actively looking for it. Worse still, lab testing for B6 status is not commonly performed. Most general blood panels don't include it, and even when it is tested, results can be misleading. Plasma B6 may appear normal, even when intracellular or functional deficiency exists. PLP is a better biomarker, but it's rarely ordered unless a practitioner has a specific reason to suspect B6 imbalance. In the absence of overt neuropathy or anemia, that suspicion seldom arises. What this all adds up to is a silent epidemic of B6 depletion, driven not by poor dietary habits alone, but by routine pharmaceutical intervention. Patients are unknowingly pushed into deficiency states by medications that are meant to help them, and the healthcare system offers no systematic screening or support. Instead, symptoms emerge months or years later: brain fog, chronic fatigue, hormonal irregularities, depression, pain, and they are treated with yet more medications, not nutritional correction. In summary, vitamin B6 is compromised by a wide spectrum of commonly prescribed drugs, but the medical system has largely failed to acknowledge or address this. Physicians rarely inform patients about B6 depletion, few test for it proactively, and even fewer recommend supplementation. This gap in care not only undermines health outcomes, it perpetuates a vicious cycle of deficiency, misdiagnosis, and unnecessary medication use. It's time to break that cycle and bring B6 status into the standard evaluation for anyone on long-term medication. The evidence is clear. What's missing is the will to act on it.